welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Now we'll have Natalee Chornak, who is a PGY2 critical care resident at Johnson City Medical Center, and she will be presenting a journal club on the effect between Etomidate and Ketamine on peri-intubation hypotension in elderly patients.
Abbreviations referenced in this presentation are listed here. And just a little bit of background. So ketamine and etomidate are both commonly used sedation agents for intubation of critically ill adults due to their minimal hemodynamic effects as compared to propofol. Previous studies comparing the risk of hemodynamic compromise with these agents have shown inconsistent results in rates of hypotension during and following endotracheal intubation. These studies previously conducted have also focused on a younger critically ill population, leaving the appropriate agent selection in the elderly population unclear. A 2022 prospective cohort study, which included patients in the INTUBE study, found that patients with peri-intubation cardiovascular instability or collapse were at nearly 2.5-fold increased risk of ICU mortality. And many factors, in addition to old age, have been found to be associated with higher rates of peri-intubation hypotension within previous literature. Despite elderly patients making up a larger proportion of the critically ill population, evidence to improve intubation-related outcomes in these patients still remains limited. Here we can compare the kinetic properties of the two most commonly used induction agents, etomidate and ketamine. So etomidate exerts its sedative effects through agonistic action on GABA receptors, and its favorable hemodynamic effects are thought to be due to stimulation of alpha-2b adrenoreceptors, which leads to a temporary increase in blood pressure via vasoconstriction. Etomidate is also a reversible inhibitor of 11-beta-hydroxylase, which can suppress adrenal secretion of cortisol for up to 24 hours. Ketamine, on the other hand, shows its anesthetic effects by antagonism of NMDA receptors with additional analgesic effects attributed to excitation of opioid receptors. And ketamine is thought to maintain its positive hemodynamic effects via stimulation of the release of endogenous catecholamines, which in turn leads to an increase in heart rate and contractility, as well as blood pressure via vasoconstriction. However, ketamine can have negative inotropic effects in states of catecholamine depletion, which can potentially lead to decreased blood pressure and cardiac index. Given previous literature has shown conflicting data related to peri-intubation and hypotension and mortality in the previous studies, the 2023 Society of Critical Care Medicine guidelines for rapid sequence intubation suggest that there's no difference between etomidate and other induction agents related to these outcomes. To better understand these suggestions from the guidelines, let's take a look at some of the previously published literature comparing etomidate and ketamine and their effects on peri-intubation hemodynamics. So this first study was conducted by Van Berkel and colleagues in 2017, and it was a retrospective single-center propensity-matched cohort study, which compared rates of clinical hypotension after 24 hours following etomidate or ketamine administration. Patients were included if they were 18 years of older and underwent RSI with either etomidate or ketamine. And the primary outcome was clinical hypotension, defined as meeting any of the four parameters listed below. I will note that in this study, the average age of patients was around 59, and patients had a baseline mean arterial pressure of mid to high 70s and low 80s in both groups. Shock scores and SOFA scores for these patients were comparable between groups, which indicates a similarity of baseline illness. However, the percent of patients on vasopressors at baseline was not reported, which could potentially confound outcomes. In this study, the authors concluded that ketamine was associated with lower rates of peri-intubation hypotension compared to etomidate, and they also found no difference in all-cause mortality, though results trended in favor of ketamine slightly, with a 31% rate in the ketamine group and 43% in the etomidate group. It's also important to note that the primary outcome assessed clinical hypotension within 24 hours following intubation, and given those short-lasting effects of the medications being investigated, it is difficult to conclude that if the hypotension was a result of the medication itself or potentially worsening of the patient's status. Also, the majority of patients in the ketamine group received either midazolam or propofol for induction, and these patients also had higher rates of exposure to benzodiazepines post-intubation compared with the etomidate group. And we do know that exposure of these medications can also contribute to hypotension, which could potentially confound these outcomes. While this study's use of propensity match scoring to balance patients' characteristics does give it a little bit of strength, the 24-hour window, high rates of exposure to known agents that can induce hypotension, limits its ability to draw conclusions from. The next trial was conducted by April and colleagues in 2020 and was a prospective observational near data set study which compared outcomes between intubations performed with either etomidate or ketamine and looked at normotensive patients 14 years or older who underwent RSI. I will note that this study, as compared to the last, only looked at a 30-minute window following intubation as opposed to the Van Berkel and colleagues trial, which does give a bit more of a reflective outcome related to these medications. In this study, patients were average around 49 years of age, and the majority of patients were from the medical ICUs in both groups. Also wanted to note that in the ketamine group, there was a slight increase in the number of patients diagnosed with sepsis, with the ketamine group having around 20% versus 10% in the etomidate group. For the outcomes of this study, peri-intubation hypotension was defined as systolic blood pressure less than 100 millimeters of mercury and was found to be more common in the etomidate group as compared to ketamine. And ketamine group also, for patients were more likely to require treatment for peri-intubation hypotension. The use of that 30-minute window strengthens the study and it more appropriately captures that peri-intubation window and the potential effects of the medication. However, the post-intubation sedation agents used was not reported, which potentially could add risk of hypotension based on agent choice. Additionally, the patient's baseline severity of illness, for example, a SOFA score or mortality risk via Apache or SNAPS-2 scores, were not reported between groups, which also could impact outcomes. Given the inconsistent outcomes and limited inclusion of patients reflective of the greater critically ill population, the authors of our next article and the focus of today's discussion look to bridge that gap by comparing etomidate and ketamine for intubation of critically ill elderly patients. This study was a prospective observational propensity match cohort study, which compared the effects of etomidate and ketamine on peri-intubation hypotension and 28-day mortality. And it included patients between March of 2022 and September of 2023 from 2 emergency departments in Thailand. And they included patients who were 65 years of age or older and received either etomidate or ketamine as a single induction agent for endotracheal intubation. The primary outcome of the study was peri-intubation within 30 minutes of induction medication administration and was classified based on meeting any of the 4 criteria listed to the right. Secondary outcomes looked at peri-intubation hypotension stratified by criteria, as well as the rates of 28-day mortality. For the statistical analysis used, looking at the propensity match scoring side of things, a logistic regression model was used, and it counted for 11 factors that were seen as potential confounders related to agent selection in clinical practice. Categorical values or variables were reported as frequencies with percentages, with continuous variables as mean with standard deviation or median with interquartile range. The primary outcome was assessed with the chi-squared test, with results reported as risk difference, and the survival at 28 days was assessed via a Cox regression analysis and probabilities estimated via Kaplan-Meier curves. Here we can see a breakdown of our patient allocation. So initially in the overall cohort, 418 patients were included. After propensity match scoring, 111 patients in each group remained. Here, the baseline characteristics are listed both for the unmatched and propensity matched groups. Specifically wanted to highlight the age across groups. Here we can see the average age of late 70s to early 80s. Patients are much older in this study as compared to some of our previous literature. Also, higher rates of sepsis across all groups, with more than half of patients in either the Etomidate or Ketamine group being diagnosed with sepsis. And then I also wanted to note the average baseline blood pressures reported, as to me and most people, I feel that they would appear to be within a normal range. Looking clearly at the unmatched side of things, I wanted to kind of highlight some of the important parts, which I thought gave insight into common clinical practice. Here we can see in the ketamine group, there was a statistically significant difference in patients receiving fluid resuscitation, need for vasopressors, and patients in the ketamine group also had lower baseline systolic and MAP pressures, which just indicates that potentially a more critically ill or patients with lower blood pressures at baseline, clinicians may be more willing or favor ketamine in that situation. The results of this study, looking at peri-intubation hypotension as the primary outcome, they found no statistically significant difference in the incidence of peri-intubation hypotension between Etomidate and ketamine in either cohort. However, there does appear to be a slight trend towards higher rates of intubation hypotension with the ketamine group. And for our secondary outcomes of 28-day mortality, while no statistically significant differences were found, again, we can see a trend in the opposite direction towards worse mortality outcomes with Etomidate. Here, the events of peri-intubation hypotension are stratified by criteria. Specifically wanted to highlight the outcomes that I felt were more clinically significant. So the first bar on the far left represents the number of patients who did not experience peri-intubation hypotension. And here we can see that trend slightly favoring Etomidate, though no statistically significant difference was found. And the final two bars on the far right, which show patients who received fluid resuscitation as well as initiation or increased dose of vasopressors, in which these patients arguably could have been more severely ill at the time of inclusion. In relation to the vasopressor outcome, while there was no statistical significant difference, if this group were truly to be more reflective of a severely ill subgroup of patients, this could potentially be more of a clinically important difference. Overall, the authors concluded that there was no statistically significant difference in rates of peri-intubation hypotension and 28-day mortality between Etomidate and ketamine used as single induction agents in elderly patients in the emergency department. And a little bit of eval. So some of the strengths I found in this study was the novelty of evidence. By bridging the previous literature gaps and focusing on more of a older population, I feel like this gives more insight that was previously not addressed. Also, the use of the unmatched analysis provides insight into common clinical practice and the types of patients in which providers may prefer one agent over the other. Also, the use of matching to limit bias and even the playing field amongst patients, especially given some of the differences seen in the unmatched analysis, I do think it's fair to even the playing field. And lastly, the use of that 30-minute post-intubation time frame is more reflective of when we would expect to see the effects of that drug, as opposed to some of the previous studies which utilized that 24-hour window. Some of the weaknesses was a single center prospective design in Thailand, which does limit the ability to extrapolate the results of the study to patient populations here in the United States. Also, the use of non-invasive blood pressure monitoring does carry the risk of inaccurate measurements, including both under and overestimation, which can impact outcomes. Factors related to the intubation process itself were not reported, so examples could include failed or prolonged intubations, which can lead to hypoxia and is associated with hypotension and increased mortality. This study did not report Any scores reflective of severe organ dysfunction or mortality risk, again, examples would include that SOFA score, Apache, or SAPS-2 score. Therefore, it is really difficult to determine how severely ill these patients were at inclusion, which may impact outcomes. While the study did include Charleston comorbidity indexes in this study, that reflects more of a baseline risk amongst patients, and it does not account for the severity of that acute illness. And lastly, post-intubation sedation was not reported as commonly used agents following intubation, such as propofol or benzodiazepines, have also been associated with hypotension and could confound outcomes. For my final thoughts, while this study does take that first step toward determining the appropriate induction agent for critically ill elderly patients, I do feel that the small sample size and single-center design really limits its ability to be extrapolated to a more diverse patient population. Also, I question if the findings of this study are really reflective of the medication itself or potentially due to the severity of the acute illness, being that the scores used to reflect this were not reported within the study. Finally, this study does highlight the critical need to assess the full clinical context and pharmacological properties of the drug while selecting an appropriate induction agent. However, in urgent situations, the immediate availability should take precedence. And that concludes my presentation. Thanks, everybody, for tuning in, and I'll be happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.